Now, to discuss about the global aspect of diabetes prevention, I am delighted to introduce Professor Dr. Peter Schwarz, and he's international expert for the prevention of diabetes, first professor for prevention and care of diabetes in Europe, MBA for international business, coordinator of large European and global prevention initiatives, coordinator of large clinical studies, and president of the sixth World Congress on the Prevention of Diabetes in national meetings. He has so many attributes. Thank you, sir. And kindly join the stage and give us the global aspect of diabetes prevention program.
Salam alaikum. I must say it's a great honor to be I think it's the 8th time to be in Pakistan, to be here in Lahore again. And it's a great honor to be here in the room at this meeting where 1,500 endocrinologists and people interested in diabetes care attended. This is the coolest message ever. So thank you very much for this. What I would like to share with you is some ideas how the International Diabetes Federation would like to address the challenges we are facing in the future. And if we are honest, diabetes care changes a lot in the moment. On one side, we have a lot of very cool drugs who are highly efficient, who are very effective, where the people have the chance to lose 30, 35, even 40 kilograms of body weight. But we move them into a lifelong dependency of this drug. Yeah, we could say this is fine, yeah, it's with insulin the same, but it's also one side of the medal. On the other hand, the burden is increasing. We face an increase in prevalence in some regions in the world, especially also here, but we also face an increase in morbidity of our patient. And this is often not touched to the full aspect, because how to treat people with a higher degree of morbidity if they have insulin resistance, if they have diabetes, if they have hyperglycemia for 30, 40 years. And we are in a century of digitalization, development of AI. And I just had a discussion sitting here in front during the previous presentation. And I asked one of your colleagues, what is your dream for Pakistan? And she said, diabetes-free Pakistan. And this is a very nice, this is a very cool goal. Then I said, what is the biggest barrier? And she said, there are two things. It's education, and the second thing is education. So education of the patient, education of healthcare professionals, this is the biggest challenge we are facing. And this is why are you here, why you are sitting here from 8 in the morning until late on the day. So again, thank you very much to you. And in this conversation with this lady, she also said AI is a part of the future. And this is basically everything what I want to do in this talk. And I would like to go through with you. You have seen the slide. The current situation is a challenge. As I said, morbidity and mortality of our patient increases. 540 people on Facebook, all the red ones, will develop diabetes. Is it a lot? It's difficult to say. This is the prevalence in Europe. The prevalence here is about twice as high. The prevalence in Saudi Arabia is more than 50%. So in Saudi Arabia, this picture would be totally red. And in this country, in Saudi, the age pyramid is opposite to ours. So 2/3 of the population have an age of below 35 years of age. So it's a big, big challenge to countries in these regions. But there's also a lot of hope on this slide, and these are the green ones. The green ones are those people who have the same risk factors than the red ones. So they walk through the door, and you say, this is a metabolic patient. And you test them, and they are healthy. So the green ones are maybe female, I apologize for what I'm saying, are female, eat a tiramisu, take the anti-baby pill, and drink a glass of white wine. This is the European model. This is a one-way road to accumulate liver fat, and today we know that 100 grams of fat in your liver is one of the strongest catalysts or progenitors for the development of diabetes. So 100 grams of fat, this is less than a handful If you have this in your liver, in the hepatocyte or between the hepatocyte, you become a non-responder for physical activity. This is a disaster. And the increase in fatty liver disease, increase in MAFLD, increase in MASLD, this is very prominent here in the region because the age of onset is much younger, much slimmer, much more female here in the region, and it's much faster. And this is what I just meant. The morbidity of our patients is increasing due to the faster development of diabetes. But the green ones, they have all this and never contract diabetes. So they have something in them preventing them from developing diabetes. It's a secret answer for prevention of diabetes. Unfortunately, we don't know. There are plenty of research groups working with this. But today we don't know. This is something we have to research into it. But we are physicians and we say we have to understand health determinants. This is the development of prevalence of diabetes in the world. The gray bar you see is the number of people with diabetes in the 80s. The blue one is the increase in number of people due to increase of population. Makes sense. But the yellow one and the rosé one is the increase in number due to the change of lifestyle. So 70% of the increase in prevalence worldwide is attributable to the change of lifestyle. And what is the change of lifestyle here? Because we could argue actually here in the region the lifestyle is healthy. Yeah? Many people are vegetarians. So it's actually a very good, very healthy lifestyle. But it has turned in the last 15 to 20 years into, I apologize for saying, into somehow the opposite due to the high degree of consumption of fried carbs. If you have carbs and you fry them at more than 130 degrees in fat, you develop bonds between glucose and fat, and the body cannot metabolize them. But you're still eating them. And what happens with these metabolites? They land in the liver. So do you develop fatty liver disease by the diet? Not you, the whole region here, all over the world, but it's very prominent here. In the conjunction with being vegetarian, it's slightly more a disadvantage. So this is attributable to the prevalence of diabetes. But there are more health determinants. If you look at this slide, you might say it's an increase in prevalence of diabetes over the next 10 years. It is not. It's the increase in prevalence in conjunction to air pollution. So here, air pollution, why is this relevant for diabetes? If you walk out of the hotel and you stand behind a good German diesel car and you take 2 deep breaths, 2 weeks later, you find medium-sized particle out of the diesel engine in your insulin-producing beta cell. Is this a problem? We don't know. If we test this in cell culture, it impairs insulin secretion by 30%. So is air pollution the new health determinant for the development of diabetes? I clearly would say yes, because the association from a public health point of view, it's there, and it's something we have to address. Prevention, prevention, prevention again is what we should do in the future. And these 2 numbers in my eyes are the ways of doing prevention. If we would be physically active per day from the age of 22, we would not contract any chronic disease. And if you have diabetes, it's actually even better by walking only 1,000 steps more. And half an hour ago, I walked here from the room up to my room in the 5th floor and came back. And this had been more than 1,000 steps. So 1,000 steps is 600 meters. It's a small distance. Everyone can walk this. It doesn't cost money. And this lowers the postprandial blood sugar by 1.5 millimole. It's twice as much what 1,000 milligram of metformin are doing. So we prescribe metformin to our patient, but walking 1,000 steps are the same as efficient. So physical activity is a cool anti-diabetic agent. But what are we doing? Yeah, this is the average step count the average German is walking. We are made to walk 36 to 39,000 steps a day. Our body, our muscles, our bones, our tendons, we are not using it. We are a lazy species in terms of physical activity. Maybe this is something we should change. If I ask the question the other way around, how many hours per day we are inactive? This is the answer. We are pretty lazy. Yeah, we are not using the potential we have in our body to use physical activity for our health. So the true diabetology is not in our brain as endocrinologists, it's not in our prescription as endocrinologists, it's in the muscle of our patients if we would be able to activate this muscle. And this is what we have to think about what we can do. But again, forget about this. Pathophysiology is important for diabetes management. This is healthy. Young women, high normal A1C, green arrows mean she's eating something. She's always eating. She's doing everything wrong. Maybe it's a Pakistani woman, it's a nurse in our diabetes ward. But the purple line is glucose, measured 1,440 times a day. And there's no elevation, there's no up and down of glucose. We thought, or in the past, we have tested far too many patients that we didn't understood what is healthy. And this is healthy. She's very, very insulin sensitive. She needs 1% of the insulin to regulate blood sugar. But here is her father, truly her father. 50% same genetic background. And the father is actually having a better A1C than the daughter, but immediately we see there's a totally different curve. In the evening, in the morning, it's the same like the daughter. And then glucose is going up and down, up and down, up and down. And today we know that this up and down of glucose drives morbidity and mortality of our patient. Imagine two patients both have an A1C of 7. One has mild fluctuation of glucose, the other one big fluctuation. The one with a big fluctuation will die because of a stroke and a heart attack. The one with a mild fluctuation maybe even don't need a treatment. And this is something in the future which can change disruptively our views onto diabetes care. The problem is we don't find them. This person actually would be exactly the right moment in an even normal glycemic state to do prevention, because here we can prevent diabetes from development. We don't find them because the sensors are too expensive. But I'm very sure in 5 years from now we will have sensors less than $1 per 2 weeks. So the future of diabetes care will look like this, to reduce the fluctuation of glucose, even for healthy individuals, to prevent morbidity for our patients. Again, pathophysiology is important. If you look at this slide, glucose is increasing. It's maybe 40 years of a patient with diabetes. Glucose is increasing, but 20 years before insulin, the blue curve is going up. This is the development of insulin resistance. All of them is triggered by the development of visceral obesity related to the release of free fatty acid out of the visceral fat. But the main driver is more than 800 known peptide hormones coming out of the visceral fat and increasing morbidity and mortality of our patient because they act in the brain, they act on the body, in all the tissues. If you have 4.7 kilogram of visceral fat, you get a dementia from Alzheimer type 17 years earlier than the average of the population. So this is actually, from the scientific point of view, totally cool information from the mechanistic understanding, but it's a very strong factor for morbidity of our population. And there is a new player on the field, and this is the hepatic fat. And look, when is the hepatic fat increasing? It's about the stage of the father I have shown, because the difference between the father and the daughter is very insulin sensitive, and the father was very insulin resistant, needs about 80% of the insulin he can produce to regulate blood sugar. And at this stage, somehow liver fat is increasing and continuously going up. And this is the catalyst provoking that the period of pre-diabetes in Pakistan is about 5 to 9 months, in Europe 5 to 7 years. So the progression of diabetes is much faster here in the region. Here diabetes starts, here we diagnose diabetes. As endocrinologists or diabetologists, we come far too late. We should think about to act much earlier to make a difference for the people, like the presentation we just have here before me. This is what we need: prevention, prevention, prevention again. The interplay between these two fat compartments, it's driving the morbidity of our patients. So now we should think about saying, okay, if this is true, what can we do to change the story? So we should remove visceral fat, and we should remove liver fat. If you have liver fat, you become a non-responder to physical activity. The only way to get the visceral fat away is physical activity. No, now it's bad. Yeah? If you have visceral fat and liver fat, you cannot do anything. Maybe you can. What is the only way to get the liver fat away? The answer is fasting. If you fast for 2 days would be good, 2 weeks without eating any kilocalories, so water diet, You initiate a release of glucagon, and the first 4 fasting days, 0 kilocalorie. Glucagon empties the storage of glycogen, and then glucagon switches on the breakdown of proteins or the breakdown of fat. So if you are fasting and laying in your bed, you break down proteins, muscle. If you fast and you're physically active, you break down fat, turn it in ketone bodies and use the ketone bodies for energy metabolism. And where is glucagon? It's in the pancreas and the liver. And that's why these 2 organs are first emptied from fat. Look at this. Let's assume NASH as a synonym for liver fat. And there is the insulin sensitivity shown. Oh, now I see the time. I am far too long. You see insulin sensitivity at the beginning and separate people without liver fat and with liver fat. And then look at the obese people without liver fat. They have a better insulin sensitivity than the slim people but having liver fat. We all know these people being slim and having type 2 diabetes because we ask ourselves why they get diabetes. And here are data from Taylor, and he has analyzed this. If you have fat in the liver, you have it in the pancreas, it destroys beta cell function. If you remove the fat out of the liver, you remove it out of the pancreas, you restore beta cell function, and you may lead to a remission of diabetes. And our experience with water diet or water fasting for 2 weeks is in about 55% of type 2 diabetes, you can reach a remission of type 2 diabetes. But we have to understand where it's coming from. If you drink Diet Coke, 1 Diet Coke per day over the period of 1 year, you increase your diabetes risk by 60%. If you use the regular Coke, only by 40%. It's odd, because we would assume the opposite, and the answer is the artificial sweetener, the last column. And why are artificial sweeteners, I will not say dangerous, why they are associated with increase of disease? Because they change the microbiome. If you eat a certain amount of artificial sweetener per day, there are 38 available worldwide, 36 change the microbiome. There are 13, and here in Pakistan, 14 different germs changing the microbiome. And this bacteria produce fatty acids. And again, it's like the fried carbs. This fatty acid we cannot metabolize, and they are in the gut, and they incorporate them, and they are stored in the liver, and they make fatty liver disease. So eating or drinking artificial sweetener becomes part of the problem. But we have the chance to change this, and smart health will be disruptive in the way how we deliver healthcare. And my dream is to be in the pocket of every diabetes patient, and building digital therapeutics could be one way to do so. And here you see the gray bars, how our agents lower A1C and lifestyle, and the blue ones, how digital tools lower A1C. And you might say, oh no, this doesn't work. How can a digital tool, an app on a smartphone, lower A1C? We are in the pocket of our patient. We never have been so close to our patient than being in the pocket of the patient. This is a totally new opportunity to deliver healthcare, to deliver motivation, to set impulses to change lifestyle. Every one of us is taking 1,800 decisions a day. 450 are related to our lifestyle. Imagine a smartphone-based app in the right moment with the right motivational strategy set impulses to influence only 10 out of the 450 lifestyle-related decisions. But over the period of 1 year, we may translate this into 10 kilogram of weight reduction. So digitalization, digital therapeutics in the pocket of our patient may help us to activate the muscles of our patient for a healthy lifestyle and a reduction of diabetes risk. Why should modern diabetology not look like this? I think this is a big opportunity, and there are examples. Germany is a frontier in this field with licensed and reimbursed digital therapeutics for diabetes care. This is a diabetes education app licensed in Germany for type 2 diabetes, using AI, making photos from the food, and the photos are used not to blame the patient for what he is eating, but to use to help the patient to make the next meal more healthy. There are others also using AI where you even qualify and can quantify the food, and again it's used based on cognitive behavior change therapy by a digital tool to help the patient to change lifestyle, apps using the glucose sensors and using the shape of the glucose curves to target nutritional coaching for the patient. And here is a Swedish development This is diabetology out of the pocket of the patient. So every patient using this sensor in this app is compared with a swarm of 1,000 other patients. And then this app is making concrete recommendation. Today, 6:35, you inject 22 units of long-acting insulin. And then it's measured whether the patient is doing it or not. And I think these are very, very cool development. And now we start fearing and say, no, we don't want this because it takes away of us our work. But think about Rwanda. Rwanda has 380,000 people with type 2 diabetes and 1 endocrinologist. So this would, and a digital infrastructure which is better than Germany. There are big, big opportunities for digital tools in diabetes care worldwide. And here are examples how neural network technology, artificial intelligence, and open language models help to educate and intervene our patient, as I have shown you. Coming to the fasting, we know eating less is healthy. Maybe eating nothing is even more healthy. And for me, is fasting for 2 weeks with water diet and many other styles of fasting. Maybe not, I apologize for saying this, today's habit of Ramadan fasting, but eating nothing or less is a gain of health, is the fastest gain of health. It can reset the microbiome, it can mobilize the fat in the liver and the pancreas. And here you see how the blue curve, how ketone bodies raise if you start fasting. And the one side, on my side, are healthy individuals, the other side are obese individuals. And you see the ketone bodies, so the effect of fasting is achieved faster for people who are obese. This is actually very cool information because maybe obese people benefit from fasting earlier and faster than healthy individuals or slim individuals, and this could be the future of diabetes care. And here you see an AGP of a person after fasting, and on the bottom line, the dark blue curve is the glucose curve, and it's very similar to the curve I showed you at the beginning from the lady. So this might be a way for remission of diabetes. MRI spectroscopy, and you see the liver, and this cloudy stuff is the fat in the liver, and this is before fasting, and this is after fasting. And I think these pictures show what is the benefit, metabolic benefit of fasting. And the International Diabetes Federation has set up a group of more than 200 experts in the world to develop a guideline on fasting and diabetes. And this is a proposal about the water diet, but there are 19 different styles of fasting, and Ramadan will be one of them we will address there. And on a metabolic level, it would be about this to achieve. So serving IDF for me as president of the International Diabetes Federation means addressing the need of people with diabetes with a clear mission that I truly believe that every person with diabetes in the world has the same right of the same quality of diabetes prevention and care. And we are not at this stage yet. We are not ready for this yet. There are people dying because of type 1 diabetes. There are people who cannot pay for the diabetes management, and there is a lot to go, a long way to go, not only to talk, we have to walk this way to improve the quality of diabetes care. And I have 3 goals. Being in the brain of every healthcare politician in the world. There are only 75,000 parliamentarians. 9,000 of them have diabetes. So it's an achievable goal. Secondly, I want to be in the pocket of every diabetes patient. And thirdly, I want to be in the heart of every healthcare professional. How do we want to reach this? First, we will develop a global diabetes index. We will measure once a year, every year, for 100,000 patients, 100,000 physicians, their perception about the quality of diabetes care in every country in the world. We will release the data before World Diabetes Day for free, so that everyone can use it to go to the Minister of Health and say, look, how is the quality of diabetes care in our country? So imagine, I again apologize for what I'm saying, you go to the Minister of Health in Pakistan, and you score at 65%. And then you see India is at 71. What does it do? So someone will think we have to improve. Maybe Minister of Health says, oh no, I ignored, stupid index. Next year we do it again. And maybe Pakistan is at 65%, India is at 74. And now the people come and say, why have you not done anything last year? And building an index, and we all know indices, stock index, other index, can be a strong momentum to initiate change. Secondly, being in the pocket of every diabetes patient. Who is in the pocket? Google, Meta, Alphabet, YouTube. working together with them to develop an evidence-based educational program for free. Think about the colleague or the patient in Congo who has no money to go to the pharmacist, who has no money to go to the physician, but has a smartphone, and we will deliver education for diabetes patients for free to them. Thirdly, being in the heart of every healthcare professional. This is you. This is you doing diabetes care. There are 1.2 million healthcare professionals in the world treating people with diabetes. And we, the International Diabetes Federation, will build a global community of people treating patients with diabetes, and this will be a fellowship program. If you become fellow of the International Diabetes Federation, there will be a QR code soon. You can scan with your mobile phone to register. If you become fellow, you get all the professional diabetes education from the IDF School of Diabetes for free. And this is what we are just in the moment leveraging. So the fellowship program will be this global community. There is an opportunity for senior fellows and honorary fellows, and this will be the strong momentum to advocate and educate and distribute evidence-based healthcare professional education all over the world. Here is a QR code. You come to this website. The fellowship program has not started yet. We will start this in 3 weeks at the RSSDI meeting in India, and if you register now, you can enter your email address and where you are coming from, and then we get an invitation email if the fellowship program is ready. If you are interested, again, make a photo from this and follow one of these channels. This is the way how I want to give the chance to witness the activities done on a global scale for people with diabetes, and it's your opportunity to read and tell me directly through WhatsApp or the other channels, say, no, Peter, I have a different opinion. You have the ability to touch the leadership of the International Diabetes Federation, to comment, to release ideas. You get involved in improving diabetes care worldwide. There are plenty of faces of people with diabetes, and with the activity of the International Diabetes Federation, we would like to put a smile on these faces of people with diabetes, because I truly believe these people deserve a better life. So follow this channel and let's work together with you sitting here, learning, educating others, train the trainer, talking to your patient, with our ideas, our intuition, maybe our controversies, but finally help the patient to walk away from diabetes. Shukriya.
Thank you, Professor Schwarz, for such an enlightening talk. Now I would like to take the comments and remarks from our chairpersons.
Thank you very much, Dr. Ebrar, for highlighting Pakistan Diabetes Prevention Program and what we have done so far and future planning. And thank you very much, Peter Schwarz, for a fantastic presentation and the global perspective. Just in the interest of time, I'll pass on the mic to Professor A.H. Amir for further comments.
Yeah, thank you, Arshad. Thank you, Ebrar, for an elaborate presentation. Thank you, Peter. But I will not start with a very optimistic note. And the reason for that is, I think it's very clear that we have lost it. Pakistan is the capital of diabetes, which means that people here, we are addressing the wrong set of population, because it's the children where we need to invest. We have lost it. We are struggling to meet ends to prevent the complication of diabetes. We are struggling to meet ends to give insulin to our patients. We are struggling to meet ends to give medication to our patients. So I think it is very clear that from that perspective, we have lost it. Pakistan has lost it, and I will be willing to say IDF has lost it. And the reason for that is we are not concentrating on children, which we should. Even if we haven't done it, we should start it. So that's my first comment. And again, as I said, it's not going to be very pleasant, because it's not an optimistic statement. The other is that if the country wants to do something, which in our case is the communicable diseases, country like ours will go to a stretch to do something to prevent communicable diseases. But when it comes to non-communicable diseases, our politicians, our governments are not interested. And I'm sorry to say, even the Western society is probably not interested because it doesn't affect them. So I think we need to do something at our end to prevent that. And when it comes to NCD, and I'll again, not in a mode in which I'm complaining, but when it comes to non-communicable diseases, heart diseases will take a priority. Psychiatric diseases will take a priority. Cancers will take a priority, but diabetes will be left in the middle. So I think diabetes is a part and parcel of all these, and it's a lifestyle disease. So I think, as I said, we have a lot to cover. I was very pleased to see that you are the first president of expert in prevention. And I think you have very rightly picked it out that the government important, the politician important is of prime importance. We have got example in one of our provinces where we are giving, free insulin and medication to underprivileged children free of cost. So that's one of the province, and that's what we are doing. But we need to replicate in the rest of the country. And I think as far as the IDF support is concerned, I think the DPP program has started. And I'm not sure if you are aware that Pakistan is amongst the 2 countries in the world with the highest younger population in the world. We are the countries which provide human resource to the rest of the world. Imagine if a young person develops diabetes, what will they end up? So it's Pakistan and South Africa, the highest number of younger population. If this youth develops diabetes, we've got a lot of chaos coming our way. So I think the DPP program is working. I think if you as a president, we can negotiate with the president that first president on prevention works in the capital or helps, IDF helps in the capital of diabetes to prevent diabetes, maybe in a cohort, but if we have a support from IDF, I think that will go a long way. Thank you very much, Peter.
Thank you very much, Professor Peter and Dr. Abrar Ahmed, for 2 very strong presentations on diabetes prevention. And what Professor Amir has already said in his comments is very valid, because the level of the epidemic that diabetes has now acquired in South Asia, especially in Pakistan, until there is a very strong political will to do something about these rising burden of NCDs, any effort that a medical organization makes would not result in a measurable or a significant change in declining that burden of disease. So governmental support, political support, and yes, collaborations with not only within the national societies and organizations, with international societies, global efforts are needed to reduce that burden. So we are doing what we could do in our capacity, but definitely we need a larger support to make an impactful change. Thank you very much.
Thank you so much.